the procedures of the spine and the ultrasonogram also. And we are also enjoying last 3-4 lectures last day and today also. Dr. Neeraj Jain, sir, he is MBBS, MD, and FIMSS and CIPS and FIPP from the USA, and the senior consultant spine and the pain specialist, spine and pain clinic, Max Hospital, and the Sir Balaji Action Hospital. And sir already give a lot of lecture for the last 1 year during COVID, and a lot of lecture from his beginner from pain specialist, and more than 170 international and national lectures, and a lot of publications, and he's the pioneer in the advanced interventional pain in India. And now I think we not to introduce more about the Dr. Neeraj Jain, sir. Now I request to start his lecture, Vertebroplasty What's New. Sir.
Thank you, Ranamul, and thank you, friends, for inviting and letting me give my talk. I think probably the best is for the last, it seems so. So I'm elated, Thank you so much, my friends. What I'm going to talk about is vertebral augmentation, and the topic is different today. It's what's new. We've been doing vertiplasty. I've been talking, routinely about vertiplasty, but there are somewhere we are receding from the normal vertiplasties and all because of the advent of medical management, very good medical management. But new is coming in for the difficult situations and difficult fractures. So we're going to talk differently today, and this is important, that way. So this is, we know it. There's the consequences. If you don't treat osteoporotic fractures, vertebral fractures, especially senile ones, there is a definitely age-related and matching increased mortality along with the morbidity all through, and it's not fair to leave them alone. So this is, when we talk vertebral fractures, not just the bone. There's so many other things. There's bone properties, there's the spine properties, which is local spine properties and global spine properties, and there are neurophysiological properties. We really have to take all of them into account when you treat one fracture. Don't look at the fracture only. When you're doing vertiplasty, you're looking like a fracture like Arjun is seeing the Chidiya ki aankh. But when you're taking person as a whole, you have to treat other aspects also of the fracture. Because fragility fracture are a mechanical consequence of a biological disease. So we have to keep that in mind. We just don't have to look at one aspect of it. Like a diabetic abscess, we don't look at the abscess, we look at diabetes also, put together. So treat osteoporosis aggressively in this situation. If patient already has got a fracture, there's all the more reason treat it more aggressively. As it is before fracture, we try to treat osteoporosis these days. And we have a very good molecule which is teriparatide, which helps many number of these patients and avoid many of these vertiplasties lately. So believe me, it's only 5-10% of patients will need vertiplasty in an osteoporotic setting even, or osteopenia at least. In osteoporosis, yes, we weigh in how bad is the fracture and what is the age and what is the total bone mass and everything into account, but then accordingly. But must give teriparatide even before you start vertiplasty, and definitely for sure after doing vertiplasty. So teriparatide, and then you can either go on to bisphosphonate, which can go for 5 years, or there's a better drug which is there, anti-resorptive medicine, which is denosumab, and which can be given for 10 years together, every 6 months injection. So this is much better compatibility wise, patient compatibility is there. And then you have to treat with calcium and vitamin D and other things. Don't take chances with these patients. So this is an important imperative. I thought I'll start with this first. Yes, there have been studies which says vertiplasty is not required, is fake, is we can do away without doing the vertiplasty. But there are recent studies which says there is a significant pain relief in favor of vertiplasty. And there is a significant better in the functional abilities or functional ability scores are better with the vertiplasty done. And on the more reason, this is there's 22% less likely to die up to 10 years after treatment of the vertiplasty. If you don't do it, or if you do it conservatively, or if you do it with vertiplasty, that's the advantage of the vertiplasty in these situations. So it's all the more important manage these patients aggressively and proactively rather than leaving them alone. Because it is seen, if you leave them alone, you look at the x-rays, it's a dynamic x-ray, very vital. You do an flexion extension x-rays in these patients, but understanding there is a retropulse fragment and how bad it is going to behave. But if there is a movement of more than 1 millimeter or 2 in the flexion extension x-ray, there is a very good paper from Japan. They did a very good study, Seto et al. They said vertebral mobility is a valuable indicator for predicting and determining bone union in osteoporotic vertebral fractures. A conventional study. Now what they're trying to say is which patient is going to unite and which patient not going to unite, which would need a surgery down the line. They try to preempt it with these studies, and they have found if there is a movement of about a 1 to 2 millimeter in the flexion extension, that means it's an unstable fracture. It will require the procedure down the line, and the worst part is they're more likely to deteriorate in the vertebral height fall and as well as the neurological sequelae. So they try to pick these cases early and try to manage them proactively, whether you do vertiplasty or do other procedures, that is to be seen. Now, which all spines are at risk post fracture? We're talking now a burst fracture where there's a middle column involvement, they are at risk of a bigger problem. Vacuum sign on MRI, that means already we're talking about the osteonecrosis. We discussed it earlier, the Kummel's osteonecrosis. And then there's a local kyphosis of more than 20-degree angle at the given vertebra. And then the retropulsion already has happened, so there is more likely the cord is going to be compressed if it goes further on, if it is not already injured for that matter. Spinal canal encroachment of more than 25-degree, this is omnious. So the whole vertebra can be pushed back, so that is to be looked at. A tricolumn injury where there is a posterior ligamental complex is also injured, so they are not good patients to leave them alone in a conservative management. Better treat them, maybe vertiplasty or maybe do a instrumentation, that is to be seen. There are so many things which is coming in lately. I'm not going to discuss because that is going to be a very long, lengthy situation. And multiple wedge compression fractures. If the multiple fractures, yes, we understand there's more of kyphotic angle. 10 plus 10 will become 20, 20 plus 20 will become 40, that will become much messy. So take them up early and do something if need be. If there is acute pain post fracture, conservative can be managed, but yes, vertiplasty in good hands is a very good option, especially in osteoporotic setting, and you already preempting is going to go bad. But if there is in neurology involved, there is already involvement, neurological involvement, surgery is the only option. But there are thought process, if there's spinal instability, you can go conservative or vertiplasty or surgery, that you can take a call patient to patient basis. But there are few things clear for acute pain, either conservative or vertiplasty in our hands, or neurology is involved, surgery is the only option. There's no other thinking. Yes, one small slide just for interest sake. For first 2 hours, pain may increase. That is to be seen. But then it keeps decreasing over a period of time, and see, study at 2 years level. This is the activity pain, this is the rest pain. The pain is reducing post vertebral augmentation. So this is the beauty of the procedure. Some people have thought of doing L2 spinal block for L3, L4 lumbar fractures, because they say the fibers go through L2, and we know it's sympathetic fibers, they last go at L2, so sometimes this thing can be helped. And they have done some studies but are not very promising, but yes, these are some studies going on. And we know about rami communicantis and other blocks, because anterior vertebral pain is gone by the sympathetic chains. This is few important pointers here. Some people do it delayed 6 weeks post injury rather than early, because then there's a less likely leak. But then there's a second point is, if they heal, and if you don't heal well, then again is a problem. So you have to really see, and you don't want to go them bad to worse in the 6 weeks time. So very close watch. I had a patient who from 1 level fracture becomes 5 level fracture or 6 level fracture for that matter in about 2 months and 15 days time. That is almost about 10 weeks time. So one has to be careful on that. Local anesthesia, yes, it is important, imperative that you don't do general anesthesia, just because you don't want to miss on the feedback from the patient if there is any neural or cord compression or canal compromise. Prone position for sure, and patient has to be empty bladder and all. Aseptic precautions, OT, linear incision, yes, important. Don't give a cross incision, give a linear incision, because you really need only 2, 3, 4 millimeter incision, don't need long incision. The 2-image intensifiers is definitely very good choice, biplane fluoroscope. But if not, then you do monoplane, but then you have to do a frequent switching, and practice this switching before you put your cement in. Uniportal or biportal based on the axial MRI CT, and you always pre-calculate, because lately what I do is I go from one side first, fill my cement in, and then see if he needs another level, I go the other side. Volume, how much? If it is Kummel's, like you just aspirate the fluid, put the same amount of cement. Don't overfill. It is said if you overfill, these cements tend to slip away. So this is important. If it is osteoporotic cavitation, then you really have a look at the MRI images the fluoro images during procedure, and that really guides you. But point is, never overfill. If you're not doing underfill, don't overfill. Underfill will cause refracture, overfill will cause a impact fracture on the other side and cement leakage. And cement preferably should be a semi-solid or a rectile, you call it, and in smaller 1 or 2 ml syringes with lure lock. So this is important leads for some patients. This is what is the cross-section vertiplasty. We are trying to go from the upper outer quadrant of the pedicle going into the anterior vertebral margin without reaching medial part of the pedicle, and trying to fill the look at the needle going in the middle of the vertebral body and try to fill. Whether you use a single needle or two needle, there is a choice. You can take a call patient to patient. One small pointer here: when we are going this way, this needle is here. You look at the AP and the lateral view. This my needle looks within the margins of the vertebral body, but I'm already out. So the idea is, I'm just giving a lead you now. Go 90° to the needle, and then you understand whether you've gone out of the vertebral margin. Because many times you see, if you've gone out, you start putting cement in, it starts leaking away, and then you start blaming. Now, it's not the fracture, it's you caused the rent there. And I said it, you go for monoplane or biplane. I explained, I normally try to do one needle first, finish with the procedure from one needle, and then see how it is required on the other side. But you normally go on the symptomatic side first, for that matter. And this is the needle, what I'm saying. If you're going two needle technique, you go more straightish in the vertebral body. But if you're trying to go with a single needle, you can go more oblique, and you can go across, as simple as that. Yes, navigate. These are new things which has come in high-end centers. You have these beautiful navigation tools, and they really are very, very helpful in these situations, and they allow you radiation-free work, or less radiation work, for that matter. Biplane, I explained you, it is very, very useful, but very less likely. I've seen Hopkins and not many centers they have biplane, but you can use two C-arm if you really want to. But I think probably we are happy with the single C-arm and doing it. Yes, another important lead is to give a little extension, and a little traction. You see there's a traction, because you want to offload the spine, anterior spine column, when you're filling the cement in, so that your cement doesn't leak out and it takes the anterior column better, or reconstruct the anterior column better. Always have the whole tool available before patient gets shifted into the OT. You should have everything on your trolley, and I want to say, keep spare needles, spare cement, and spare of everything, even bowl cement, mixing bowls, spare of them if you want to, and use smaller syringes. There are some needles available which are angle needles. Now some people are starting to use angle hook also, and they can elevate end plates with the hook, and then they fill the cement in through the same port where they're going inside. This is another thing which is there. You can go directional the way you want to put cement in. This is how I was saying, 6th level cementing. This is actually 2 months and 17 or 18 days. He had only 1 level fracture here. He had 6 level fracture, and because he was left alone to rest at home and conservatively manage. And see, this is what he was in very big pain. So I did all 6 in one go, one time, one OT, and this was world record in 2010. And thereafter people started doing more. Why they were not doing more? I'll explain you that, because there was a study. Another point here is, when you have so many levels you go inside, you try to go from the opposite side, because you don't want your needle to fight like this, because then it becomes very difficult to inject cement from the same side. So try to avoid. The reason why people didn't do more than 3 at a time was because there was a bone marrow which used to get embolized, and there was a embolization into the pulmonary circulation, and it used to be a very big problem. After that realization, people are starting aspirating bone marrow, like we do a bone marrow aspiration thing, everything, BMAC and all, bone marrow, and then start injecting cement in, because once you inject cement, your bone marrow will obviously get pushed out. And there is a study, there's a very good study which is done. They found the cement is right inside the vertebral body. It is the bone marrow which has gone onto the lung and caused the death of this patient. So this is a specimen of that. So this is important to realize. There are sometimes situations where your cement leaks out of the end plate. There's end plate fracture. This is very common. And cement may just leak out of the end plate. Don't you worry. Just stop as soon as your cement leaks out. Just stop. Let the end plate defect seal, cleft seals, seal by itself, and change your needle direction, or change needle if you want to change needle is getting blocked. Don't let you get needle blocked, and then you restart your cement injection. There have been some situations now lately. People are doing cement discoplasties. We know about disc replacement, discoplasties and all. People do multi-level procedures, and they put a cement inside bone, disc, and they cause a fusion. So this is one new thing which is coming. The people are doing it now. The surgeons are doing it very often, and it's very in thing these days. Another important point is, have your cement beautifully seen, because you have to see each drop of your cement going inside the bone. Don't you inject cement in until unless you are in lateral fluoroscopy view, until unless you have a live fluoroscopy, because that's where the whole accident happens. You inject without seeing, and just in one go, one push, and the cement leaks into canal, and that is a hell. Then you really can't do much about it. You can aspirate from bone, but not what to do with the canal. So this was my paper in the World Congress, And this is what I'm trying to say. When you're trying to make cement in, I do put in a radiopic dye. We have omnipic dye in all procedures. I have found nobody has done it, but I started doing it long 15 years back, and just to pacify the cement. People have barium sulfate and all, but it was on my table. I never changed the quality of the cement, hardening of the cement, and I mix it and put in a cold saline bowl for that matter, because it's a ice cold saline, because it gives you more procedure time, and this procedure time depends on the temperature of the cement. If cement is colder, it gives you more time, although there are slow setting cements available now, so this is not much of a problem. There are new developments which are there is the non-PMA cement is bioactive glasses, all those composite cements are there. What are the cement volumes? I told you, neither under nor over. And what are the variations? And with the balloon formation, you don't have to worry, because you already have a volume with you with the kyphoplasty. And there are some technical variations, we'll discuss it. They are already saying calcium phosphate cements are better because they're osteoconductive. They have a good rhodiopassivity, and the temperature is not high when they are getting hardening. So this is one advantage, and they say when it's osteoconductive, over a period of time gets reabsorbed and your bone takes over, but not to be used in a severe osteoporotic fractures. Please understand, because the bone will never reform there. Another development is adding the chemotherapy agents, radioactive isotopes in the malignancy setting, because then it tends to kill, because there are situations we're doing in malignancy setting, what to do with the tumor. So either you do a RF of the tumor, which we're doing, or you do these drugs like we know RT works good in these patients. There's a small study which says there's not much of difference when they use a low viscosity or medium viscosity cement, but I am not happy with this study, because I do feel in such situations like vertebral hemangiomas and all, I would rather definitely put a harder cement in, or in kyphoplasty for that matter, instead of a slow flowy cement which tends to leak out very often, and I'm not very comfortable. So I normally take a semi-solid carbon cement which kind of leaks out like this, not drop by drop. Is there is a formation, like a thread formation like this, and then you start injecting, keeping the cement cool in the bowl. That really helps you, because you take multiple times if need be, if you have 1 or 2 ml syringe. Like I told you, this is vertebral hemangioma, you just fill in like this, and you don't have to really worry about the any leak into the canal. So this is important. Just where you are putting your cement in. That's the whole idea. And this is about the multiple levels. If you have to do this, the kyphon, I told you, when the kyphon, you make a space first and then put cement in. This time you can put a harder cement. You don't have to worry. Your cavity is there. You make a void first, cavity first for the cement, and definitely you elevate the end plates. That's meant for the collapse fractures, for sure. That is obvious. I'm talking something new, so I'm not discussing those details. Now this one is there, height restriction is there. This is actually collapse, vertebral plana. I have another case to show you, and you kind of inflate the end plates first, elevate, and sagittal correction is done, and then you put a cement in, and that's the philosophy. And when you do this, you do a traction and extension in these patients. I explained earlier. This is important, that instead of putting a PMA cement like this in those situations like osteonecrosis, or when you have a big volume coming, because these cements, they might glide out or slip out like a ball, glass ball. So you put a kind of integrating cement like this, and these are the other cement which I told, CP and other cements, or HA, hydroxyapatite cements, which kind of integrates into the trabeculae. So important. Now this is a flow chart, by the way. If there's a percutaneous treatment to be done, and you don't want to restore height, you go for, and you don't want to create void, go vertiplasty. But if you want to restore vertebral height and not to create a void, there's another thing which is coming in vertiplasty. I'll discuss it in a minute's time. And if you want to create a void with the mechanical pressure, then we have all these things coming in: optimesh, acuplasty, other thing is sky expanders. Or if there is hydrostatic pressure, we have a kyphex, and these are things, or kyphon for that matter, kypho balloon. They are very, very helpful. Now this coming to the point is, this is the vesselplasty, and you put inside vessel, and the cement gets into the vessel and integrates. There is a pores which cement leaks out of the pores and integrates into the vertebral body, so it doesn't slip out then. There are sky expanders. Now people have coins, expanders, so many things, and jack. It opens up the vertebral height, and they want to put in cement or not. It's a choice. Like this is another level of mesh plasty. Isn't it vesselplasty? Put inside, inflate it open, and you have a mesh, and you put a cement inside the mesh and leave with the mesh. These are mesh plasties. Now another one is a expander inside, like a jack in the car, and elevate the end plates, put cement inside. One small lead is, don't touch the cement at the end plates. Avoid it. This is the right way of doing it. because more you touch the cement to the end plates, more likely that the adjacent vertebra gets fractured. And another lead is the Camus triangle approach is there lately. People are doing, when they are combining with other procedures, they go through the end plates instead of going through transpedicular, through the end plate, and put the cement inside. This is another very good lead when doing this procedure otherwise, and you seeing an end plates from inside. And this is the technique which I was talking to you. New technique, that percutaneous endoscopy, decompression and vertiplasty in patient with osteoporotic fractures. Here what they are doing is they are trying to decompress the fracture. If there is a fragment inside the canal and they kind of free floating fragment, take it out and then put cement inside. And this is it. And there are situations where you might have to take cement out. You should be expert at it. Some endoscopic surgeon, they will do it. They can take it. Now this is the cement leaked inside the epidural canal. This is bad. There are situations we've been called in and we try to put inside the stimulator leads and try to manage the pain if it is possible. And one beautiful thing is the DRG stimulation is there lately, and if you have a monopole or monoradicular pain, then you can manage with these situations. They are helpful. There are polytrauma settings. There's a fracture, you put cement inside, you can manage it. What I'm trying to tell is burst fracture can be managed if you're doing it well and if you're doing with the technique which I'm going to show you in 1 minute time. Or you can do in upper thoracic vertebra also, D5, D6. If you understand where you have to go, the costotransverse junction, go inside and cement well inside. And this is a C2 transoral fracture there, and you go inside and you just put cement. This is one of my patients who was having a CVA. 4 surgeons refused for the surgery, so I was pushed to do this. But yes, it is very much doable. This is a patient sitting in my clinic after the procedure. Now this is I call a hybrid procedure. You can do with fluoro plus CT. You can be right in the CT room with the fluoro, or I put my needle inside the fluoro room, take the patient to the CT with the needles covered and put my cement in there. And you really should see each drop of cement here because your roots are very close. You don't want to mess with the roots there, and that is important when you're reinforcing sacral insufficiency fractures or sacral hemangiomas. This is non-union. This is common osteonecrosis. You look at the 6th level, already we put screws in, and this patient was really crying up pain here, and there was a void there. So just go wet inside, put my balloon in there. This is typical, technically challenging. This is D8 vertebra most likely, and put cement inside. At the end of the cement, look at the incision line. What surgery they have done. If it was primarily with us, we would have done just this puncture and done the whole job. So we don't have to go for the whole big thing. And this is the patient very next day walking inside the ward, So you can make changes. You can do changes for this patient's life. This is treating metastatic fractures. This is a fracture metastasis. This is what it is. Radioablation with the RT, they have shown much better results, 93%, than any of these alone. So they have shown much better results. So think for those things, and it's available. It's available now. This is just last few slides. This is senile osteoporotic fractures or metastatic fractures. There's a cord compression, and patient is not good for surgery. You have to do something. And this is the last thing, which I have devolved a technique. This NJ, anterior epidural safety balloon technique. This is where we have to do the procedure, and this is we going at level 2 from below and go transfemorally, get into the vertebral anterior epidural space, and just behind the concerned vertebra, put a balloon in there, inflate it there. You can really see when you're inflating the kyphon, it's not retropulsing, and you're really looking at the things, and then you're trying to put the cement inside, you're plugging the leak. So this is what it is. At the end of the procedure, you do a myelogram, and that's very ensuring, and you have a good night's sleep, And this is the last patient, and this is vertebra plana. Means I said with proud, she was 86, not able to go for anything, but she was in pain. Very, very courageous thing. And then we could manage, we could really open up this fracture vertebra with the balloon. You can see only anterior column reconstruction. Please understand, don't go back, because then you're more compromising, and put a cement inside the end of it. And in the next slide, you will just see what this is vertebra plana. We could raise the height. Look at the sagittal deformity, and we could increase the height, anterior column, and the sagittal support was there. So patient was comfortable with all this dual balloon technique. One balloon inside. Dual balloon is not two sides balloon from both pedicle. One balloon inside the bone, one is in the posterior to the bone, and that's where we can manage these dirty fractures, which are which is, you cannot do this vertiplasty otherwise in those situations. So you count your blessings with all these patients. They are not able to go for surgery. They don't want surgery, and you can really give them a life back, the back into life in the older age, It's a very, very bad situation to go that sick. So this was I presented in antiepidural balloon neuroplasty foraminoplasty. That was an innovation. So at World Congress I presented. Yes, in vertebral augmentation we can make it safer for wider application like in burst fracture, vertebra plana, or with the balloon thing in some situations where there's a cord compression doubtful and multiple level fractures. But do it safely, do it effectively, do it wisely. And yes, teaching is learning. I love talking, as Dr. Anomal said, Milton said. Yes, I tend to talk as much if get a chance to share my experiences and can uh, give back to the society as much I can. Thank you so much. And any questions, you're more than welcome to ask. I'm there for you, my friends. Thank you so much. Thank you.